Behavioral health is a key focus at NCQA's 2025 Health Innovation Summit, October 13th to 15th in San Diego. I'm Andy Reynolds. For a preview, I spoke with Kate Hobbs, CEO of Author Health and an advisor to NCQA on the summit's behavioral health agenda. Kate, welcome.
I'm delighted to be here, really appreciate the invitation, and I'm excited to talk about these questions and ideas and issues that are so near and dear to my heart.
Behavioral health is a vast topic with many implications and branches. How can newcomers or occasional visitors to these topics break behavioral health care into manageable concepts?
It's such a common challenge. I've experienced that people think it's one thing, and it's not. It's many things. One of the mistakes we have made as a field is trying to find one solution. And there really isn't one solution that's going to work across behavioral health. Behavioral health actually is an umbrella phrase to encapsulate both mental health, so conditions like depression, anxiety, PTSD, and substance use disorder. These are two areas, mental health versus substance use. Oftentimes, these conditions are co-occurring. The other major distinction is age. The conditions children and adolescents experience are quite different than what adults and what elderly people may experience. There's very important distinction in what conditions people are going to present with and what treatments are appropriate and who's involved in the care. Another important distinction is mild to moderate conditions versus more severe and complex. Mild depression, mild anxiety, maybe grief, so time-limited conditions, insomnia. These are things that are more mild to moderate. Then the next category is more severe and complex, things like schizophrenia, bipolar disorder, some eating disorders, et cetera. Those distinctions are important for how we think about quality. The last piece I'll call out is payer source. Services available to a patient insured by commercial insurance are quite different than people who are insured by Medicaid or Medicare. There's state grants, services provided through different components of the state that are another dimension of how we need to think about the care. Author Health is very intentionally a value-based care company. We focus on Medicare Advantage and special needs plans. We work with health plans and primary care groups to identify members with serious mental illness, substance use disorders, dementia, and we are accountable for the total cost for that population with these conditions.
Okay, to recap, you've given us 4 ways to parse this broad topic of behavioral health care. First, mental health versus substance use disorders. 2, the age of the patients involved. 3, the severity of the conditions, that is mild, moderate, or severe. 4th, payer source, that is fee-for-service versus value-based care. And I'd like to loop back to you on that 4th piece, the payment model. But first, this is NCQA, so I have to ask you your thoughts on quality measurement. What is high-quality behavioral health care, and how do we know it when we see it?
One thing that's really fortunate that is also often not understood, we already have a lot of measures in behavioral health that are clinically validated, that are widely used. So in our field, it's about increasing awareness of those measures and increasing adoption across payers, providers, and other groups. We think in terms of structural measures, process measures, and true health outcome measures. And within behavioral health, we have different outcomes that fall into each of those. Additionally, we like the quadruple or now quintuple aim. So thinking about quality in terms of health outcomes, patient, family, and provider experience, cost of care, and health equity.
How should we measure behavioral health care that's delivered virtually? Virtual care exploded during the pandemic. Many people like it, and it seems like it's here to stay. But how should we assess virtual behavioral health care?
We really should treat them the same. Like any other outcome measurement, we want to be focused on the health outcome. So this service, whether it was delivered in person, whether it was delivered by telehealth, did it result in the health improvement we aim for? In behavioral health, the measure of symptom improvement is rating scales. So things like the PHQ-9 for depression, GAD-7 for anxiety. Almost every mental health or substance use condition has an associated scale that can be used at baseline to identify how severe is this condition. But if you're measuring over time, the other thing we've thought about, should we be measuring these scales using a 360 approach? Should we be hearing from the patient and their family and the clinician and putting together a composite measure, for example.
I've read that persistent passive measurement using digital devices holds a lot of promise for behavioral health care. What can you tell me about that?
There are some advanced ways that the field is going, some passive ways we may be able to measure health outcomes and function through smartphones, wearable devices in terms of sleep or even anxiety that you could capture through heart rate or sweat. Passive ways that we may be able to measure the key outcomes related to treatment in behavioral health. How a person uses their smartphone tells a lot about their mental health, changes in how a person uses their cell phone. Looking at things like the emotional valence of a text, the tenor, you could tell potentially a more optimistic or positive mood versus a more depressed mood. If you see high frequency engagement with positive tenor that then changes to less frequent with more negative tone in a person who has depression, that could be an indicator of an exacerbation of depression. Similarly, you can measure activity. How frequently is this person out of their home? How much are they exercising? Sleep is the underlying challenging symptom for almost every behavioral health condition. So being able to monitor sleep using smartphones or other devices is another way to measure for exacerbation or track progress. Where we have to be aware is none of these technologies are perfect. They're also new. We have to study them, make sure they're accurate, make sure that there's adequate privacy and protection. We have to have an eye towards those things as we innovate.
Some people think about behavioral health care as a trinity or a three-part model of quality, access, and payment. You've told us how you think we should measure quality. What do you wish more people understood about access to behavioral health care?
There's a lot of complexity when you're treating people with severe and complex mental health and substance use disorders. We have lots of treatments that work. Buprenorphine for opioid use disorder, or antipsychotic medications for psychosis. The problem is getting treatment to people when they need them in a way that's convenient and where they can engage in care over time. There's rising suicide rates among young people and also elderly people have a difficult time getting access to psychiatric medications, psychotherapy, et cetera. A lot of times behavioral health care is provided in different silos and separately funded, especially state-funded services, maybe provided through Medicaid, the justice system, the school system. Services provided in different places and separate funding streams makes things more complex, but also can lead to difficulty delivering coordinated and safe care. People with mental health, substance use disorders, dementia can have even more difficulty accessing care. Imagine someone with active substance use or active psychosis. It can be hard to connect with primary care or behavioral health services. A lot of times, these individuals go without treatment at all. Some studies show there can be a gap of 10 to 15 years between the initial onset of symptoms and accessing treatment. As a result, this population oftentimes is engaging in what we call low-value care. So less primary care of outpatient behavioral health services, more crisis-driven care, ending up in the ED, the inpatient unit for medical and behavioral issues that are driving a bad experience for the patient because they're continually in crisis, but also driving up healthcare costs. And if we deliver high quality behavioral health care earlier in the course of the person's condition, we improve health outcomes, we improve the patient's experience, but we also improve costs overall. And that person is more likely to reach recovery and maintain function.
To build on what I was learning from Kate, I spoke with the person at NCQA who is in charge of behavioral health care.
Hi, I'm Julie Seibert. I'm the AVP of Behavioral Health at NCQA. I was struck by what Kate said about lack of access to behavioral health services. We've been hearing that at NCQA, and NCQA is trying to develop a measure of network adequacy. We're finding measuring access is really complicated. There are issues related to geography. Access looks different in rural and urban areas. There are issues with regard to provider type. There are a lot of different types of providers that provide behavioral health services. Are we looking at psychiatrists? Are we looking at licensed master's level? Are we looking at psychologists? Prescribers include psychiatrists, primary care providers, nurse practitioners. Is that a better way of categorizing who's providing behavioral health care? Non-prescribers can include PhD level psychologists. They can include master's level social workers. or marriage and family therapists, also certified peer specialists. So there's a variety of individuals that could be included in that non-prescriber provider category. Also, measuring access can be complicated if you look at modality. Are we looking at virtual provision of care? Or are we looking at in-person care? Finally, the type of treatment is another consideration in measuring access. Behavioral health care is not just an office visit once a year or weekly. Behavioral health care can include intensive outpatient care. It can include care coordination or care management. So there are lots of different things we need to look at when we're looking at access.
Thanks, Julie. Kate, let's turn back to you. We've talked about quality. We've talked about access. Now let's talk about the third piece of that behavioral health trinity. And I know you have a strong feeling about this one, payment. What do you wish more people understood about payment for behavioral health care?
Fee-for-service payment breaks all of healthcare, but in particular, it breaks behavioral healthcare, or breaks high-quality behavioral healthcare is what I should say. Be it telehealth, in person, when you deliver the service, you get paid. It's challenging for two reasons. One, high-quality behavioral healthcare requires a team. You have to have an MDA or DO psychiatrist, nurse practitioner, LCSW. You've got to be thinking about the family, the school, the primary care provider. All of these have to be working together if you're going to deliver high quality and coordinated care. That coordination is not paid for in fee for service. When you call the PCP or you call the school, that's not paid for. And it's very hard to deliver that care at scale when it's not funded. Additionally, almost all of our patients have health-related social needs. You have to be interacting with the patient in between face-to-face visits. And there's so much between visits that's critically important that are only funded when you have value-based payment. It really hit home for me when I was early on in my practice, where I had patients that would show up reliably. I had really good handle on what was going on and we were making progress. But then there were patients who wouldn't show up. A lot of those patients did have substance use disorder. My first thought would be, oh my goodness, they may have relapsed. And I have no way to find them. I can call them, but I have no way to get to them. From a health system perspective, from a society perspective, we need to be doing everything we can at that moment to go get that patient into care. But in a fee-for-service environment, not funded. I'm only paid as a provider for that patient who's showing up. Oftentimes, that's missing the patients who have the highest vulnerability. The other piece is that fee-for-service incentivizes cherry picking. Patients who are able to show up for a face-to-face visit, it takes a lot of work, right? You got to call or you go online, you got to schedule the appointment, you got to get your transportation, or you got to get your Zoom in line, and you got to show up on time. Almost every mental health or substance use condition impacts executive functioning and a person's ability to take those steps. So the patients who are hurt the most are those with the most active conditions, active substance use, active psychosis, things like that. Those are the patients who have the hardest time showing up for these visits. In a fee-for-service environment, they get fired from the practice because there's too many no-shows. A practice can fill their practice with patients with mild to moderate conditions that are able to show up reliably so the provider can bill. Those patients that are the most vulnerable that can't do that then are left without care, and they end up in crisis in the hospital.
Wow. So it sounds like fee-for-service is a terrible fit for good behavioral health care. Tell me about the alternative, value-based payment.
If you make the provider accountable for a whole population, you say, you're responsible for everybody with mental health conditions in this geography. Regardless of whether they see you or not, you're accountable for their health outcomes and their costs. Now that provider is incentivized to go get that patient who's most vulnerable, who's going to show up in the ED or inpatient, get them into care. So send out on-the-ground resources, call them, do everything you can to get them into care and overcome the vulnerability that they have because of the condition. Changing that incentive is critically important in our field, and funding that work to get that patient into care is really important. We cannot exist with fee-for-service. We have to move to a value-based approach. And so you've seen progression in behavioral health with payers and states moving towards value-based payments that are holding providers accountable for quality. That gets me excited because that's going to help us move the needle and fund the resources we need to help people get better. So I'm excited about that. I'm excited about technology and how it can help us extend our workforce and the adoption we've seen, not only telehealth, but also wearables. I'm excited about advances in care delivery in the measurement of quality and changes in the payment model. So our ability to advance payment. Underlying all of that is advances in technology that are allowing us to extend our workforce and measure outcomes at a broader scale.
Thank you. I like how you put that. Why don't we close? As you know, the purpose of this podcast is to help people who are curious about quality get smarter on these topics. So what are you most curious about in behavioral health care these days?
I'm curious where we will be and how quickly we will get there. We've talked about advances in technology in value-based payment. Will we be able to continue at this pace? Will there be even more advances that we had never considered? Will the delivery of behavioral health care look more different in 5 years than we can even imagine today? Those are the things I wonder about and that also get me really excited. The core of this is people suffering every single day as a result of these conditions and that are having difficulty getting the access to care they need. We see it in having difficulty working and suicide rates, difficulties within their families, et cetera. We have to rethink how we deliver and how we pay for behavioral health care. I get really excited and want to see the full realization of the potential that we have through these technologies and changing the payment.
I think that's a great place to end. Kate Hobbs is the CEO of Author Health. She has advised NCQA on behavioral healthcare topics that NCQA will feature at the Health Innovation Summit. Kate, thanks for being here and thanks for the background on behavioral health as we head to the summit.
This is a great conversation. Really appreciate the questions. I'm delighted to be here.
You can learn about these and other quality topics at NCQA's largest conference of 2025, the Health Innovation Summit, October 13th to 15th in San Diego. Learn more at ncqa.org/events.